So, good morning to all. So, today I'm starting my second case series where I will discuss with you all about a very important case, that is accommodative spasm. So, let's start. So, here you can see that uh, the child is 14 years of age, male, and wait a minute here. So, he is 14 years of age, male, came to our clinic where the parents were complaining of blurring of vision for distant near since 3 days, and the patient was not giving any history of ocular and head injury, and the patient was not also having history of using glasses previously. So when we taken the birth history of the patient, then the patient was having normal vaginal delivery and it was 36 weeks, and the birth weight was also 2.5. That's quite very much normal. The patient was not having any postnatal infection, sepsis, and no history of fits was also there. And the vaccination status was up to date, and birth cry was also within normal limits. So here in this slide, you can see that the patient visual acuity is quite reduced and the pinhole visual acuity is 20, 120, 80. Okay. So here, when we did the dry retinoscope to the patient, then initially it was showing that patient is having higher minus value, that is minus 4.5 in the both eye. But when we did the cycloplegic refraction to the patient, then we saw there is a hyperopic shift of the refractive error. So generally, this type of hyperopic shift to the refractive error is mostly seen in accommodative spasm cases. So here you can see the patient is complaining of blurring of vision for distant near since 3 days, and you can see there is a hyperopic shift to the refractive error from high myopia to hyperopia. Why? Because the patient was having history of uh, prolonged near activity for a prolonged period of time. So it was leading to uh, uh, spasm of near reflex. That means accommodative spasm was there, and now the accommodation was in spasm mode, and it is activated for distant also because the patient was not able to relax his accommodation. So at that time, the patient was generating higher plus power for the distant object. So it is ultimately leading to myopic shift of the patient, and patient turn to myopia. So that's why whenever you are getting a patient of accommodative spasm, you will see that the patient will complain of astronomic symptoms with dimness of vision for distance. And when you will take the visual acuity of the patient, then the visual acuity will be not stable. It will be unstable visual acuity, that means unreliable, and the visual acuity status will not match with the refractive status of the eye, as well as you will see vacillating reflex. Means sometimes you will see dull glow, sometimes you will see bright glow, something like that. So that's why you have to do cycloplegic refraction to all those children. And here you can see by doing cycloplegic refraction, you can see hyperopic shift of the refractive error. That is indicating, yes, it is a case of what to say, accommodative spasm. So as I told you that accommodation is active for distance. So which accommodation? Convergence is also there. So because of the activation of the convergence, ultimately you will see esophoria, and in later stage it can lead to esotropia also. So in this patient, we decided to give the patient full cycloplegic refraction, that is +1 in the both eye, and the vision turned to 20/20, and near vision was 6/6. So we given this correction. But you have to tell the patient, don't go for the higher expensive glasses because this lens or this prescription can also change. So that's why you have to monitor the patient in a close follow-up manner. Okay. So here this is the ocular examination where you can see the patient is having central on equity, esophoric is there, and here the patient was orthophoric for distant near normal. Initially you will see orthophoric, but when you will do the cover uncover test, you will see that patient is esophoria. Now we decided to prescribe high homide eye drop to the patient also, so that the patient will not generate accommodation for distance, and with homide or cycloplegic eye drop, give the full correction to the child. And we decided to call the patient in a 2 weeks of time. So in this time also, the patient not made his glasses. He came to take his glasses, but he decided to come to the clinic again. So at that visit, we measure, and you can see that the previous visit was 2400, 2320, but after 2 weeks when he came, it was 2800. The vision is not at all stable. Why? Because of the spasm of accommodation. So that's why vision is unstable. Pinhole acuity was 320, but previously it was 2000, something like that. So that's why you can't rely on the vision. You have to do retinoscopy very nicely. So here in this visit, we tried to do retinoscopy, but it was showing very much vacillating reflex. So, and the patient all taken his glasses that we given earlier, that is +1 in the both eye, and we again told the patient to continue the homatropine eye drop and call the patient after 2 weeks. So when the patient came after 2 weeks, then we saw that the patient isophoric was there, okay, uh, and also there is quite vacillating reflex was also there. And here again the patient was told to continue the glasses and homatropine was given. So when the patient again came after 2 weeks, this because we are following the patient in 2 weeks of interval. Okay, so here the when we taken the unaided visual acuity, it was 2000. That means it was quite improved than the last visit. Then also the patient was quite complaining of diplopia. Okay, so here what we told the patient is we told the patient to stop using homatropine, because by using homatropine also the vision was not that much improving. So that's why we shifted to atropine eye drop in a twice a day, atropine 1%, and also told to continue the glasses. Here you can see that shift to atropine is there in twice a day. Okay, so here after that, when the patient came after 1 month, then you can see that unaided visual acuity was quite very much improved, and with correction, it was improving to 2020. Okay, so here we again did the retinoscope to the patient. It was showing +1. So here with this +1, now we decided to reduce the power. So here we given +0.75. This is the cycloplegic refraction. Okay. Uh, so here 2020 vision is achieved, and for near it is N6, and here patient eyes will also be shifting to orthophoric side. So it is a case of accommodative spasm, where because of the prolonged near activity, the patient generated accommodation and it was in a spasm mode. So that's why the patient was not able to relax the accommodation, and he was generating this accommodation for distance. So this is why the patient shifted to myopia. So that's why you have to give the patient cycloplegic eye drops to reduce or to stop the patient to use the what to say accommodation, then give the full cycloplegic refraction. Now you will need to call the patient in a close follow-up manner and see what is the improvement of vision. Okay, suppose even after giving this all these things, the patient vision is not improved and the accommodative spasm is not treated, then you have to go for uh, Boris delayed subjective refraction. And with this Boris delayed subjective refraction, decide to give the patient cycloplegic eye drop. So this is how you can treat in a very severe type of accommodative spasm cases, or else you can follow like this, where we followed in this patient, where give the full cycloplegic eye drop, cycloplegic correction with give cycloplegic eye drop. And if you see that by giving weaker cycloplegic eye drop like homatropine, the patient symptoms are not getting resolved, then go for the stronger cycloplegic eye drop like atropine. And if you are giving the patient atropine eye drop, then do prefer to give what to say near vision glasses like +3 or +2.5, so that the patient will not feel any difficulty to see the near object clearly. Okay, so that's all, friends. Thanks for watching. And please don't forget to like my video, subscribe to my channel, and I hope this case also helped you quite a bit to know what is the management and what is the clinical presentation of accommodative spasm cases. Thank you so much.